good afternoon. I'll be talking about beyond inhibition, exploring the unique molecular properties of anti-VEGF agents. So this is a disclaimer. So several molecular factors determine how a drug interacts with the body: the binding affinity, the elimination half-life, the potency, the clinical targets, and the molar dose. So individual studies assessing the molecular properties of intravitreal anti-VEGF agents have suggested that there are key differences between agents in terms of VEGF binding affinity, relative potency, and intraocular half-life. So binding affinity determines how strongly a drug interacts with its target. So we can see here a comparison between the different anti-VEGF agents, and this is data from head-to-head studies in the binding affinity with VEGF, where we can see that aflibercept was found to have statistically higher VEGF binding affinity than brolucizumab and ranibizumab in a head-to-head study. Potency determines the required concentration of a drug to produce a defined effect. So again, this is a data from head-to-head study of the potency of these various drugs, where you can see that aflibercept is significantly more potent than brolucizumab and ranibizumab in vitro. A lower IC value means increased potency here. So you can see here a potency of 2.42 for aflibercept. Half-life provides an insight into the drug concentration in the body over time. And data from independent studies where you can see that the estimated human half-life of aflibercept is about 9.1 to 11 days, which is more than that of ranibizumab and faricimab, and also of brolucizumab. Binding target determines downstream effects of a drug on disease pathology, and we can see here that aflibercept binds not only VEGF-A but also PIGF, VEGF-B, and galectin-1, as opposed to the other agents which bind predominantly VEGF-A, and in case of faricimab, Ang2 as well. So currently available and approved anti-VEGF agents, this is again a comparison of the binding affinity, estimated human half-life, equivalent molar dose, number of targets, and potency, where you can see that the aflibercept has multi targets which are being targeted, and the potency is 2.42. So the VEGF receptor signaling pathway is the master regulator of pathological angiogenesis. However, in pathological conditions beside VEGF, PIGF levels also are increased due to hypoxia. This is a cartoon depicting how that happens. Aflibercept significantly decreased intraocular VEGF and PLGF levels from baseline to month 2 in patients with DME. And VEGF and PLGF are upregulated in exudative retinal diseases such as diabetic retinopathy, diabetic macular edema, and neovascular AMD. Here you can see that in patients with DME, VEGF levels are up to 61 times higher, PLGF levels are up to 19 times higher. In patients with RVO, they are 154 times higher and 14.5 times higher respectively. In high VEGF states, Ang2 blocks the Tie2 receptor, increasing vascular permeability and neovascularization. So how relevant is targeting Ang2 to managing retinal disease? VEGF is a pivotal mediator of pathology in retinal disease, increasing the vascular permeability and the formation of pathological vessels and macular edema. Inhibition of VEGF can reduce the incidence of these events. Ang2 level can be suppressed with any other anti-VEGF, aflibercept, ranibizumab, and bevacizumab. So we know that the results of this study support the hypothesis that Ang2 may be expressed secondary to primary insults to retinal vasculature by VEGF, and direct inhibition of Ang2 may not be clinically relevant, as this is currently provided by anti-VEGF treatment alone. Baer and Regeneron have investigated the Ang2 pathway in combination with aflibercept in the Ruby and the Onyx studies. This is data from independent studies shown here, where faricimab has a weaker binding affinity for Ang2 than for the Tie2 receptors, and nesvacumab has a stronger binding affinity for Ang2 than for the Tie2 receptors. So no additional clinical benefits have been found with potent Ang2 inhibition in combination with aflibercept in these two studies, that is the Ruby and the Onyx. And it was discontinued primarily because combination therapy was non-inferior to aflibercept monotherapy for change in BCVA at week 12 and week 36 endpoints. There was no efficacy improvement noted in neovascular AMD or DME. Therefore, aflibercept ANG2 program was discontinued. No vision benefit with faricimab versus ranibizumab in neovascular AMD. In the Avenue study for neovascular AMD, no statistically significant difference in BCVA and in secondary functional or anatomic outcomes between faricimab and ranibizumab were observed. So in Avenue, ranibizumab and faricimab achieved similar levels of plasma ANG2 inhibition after one injection. In Avenue, again, you can see here that data suggests that anti-VEGF monotherapy neutralizes ANG2 to levels comparable to that of directly targeting ANG2, supporting the known biological activity of ANG2, whereby its activity is downregulated by decreasing VEGF-A levels. In an FDA review comments on relevance of ANG2 in retinal disorder, it says that the contribution of ANG2 inhibition to the treatment effect and clinical response for neovascular AMD and DME has yet to be established. No vision benefit was again seen with faricimab versus aflibercept in neovascular AMD in various studies like Yosemite, Rhine, Tenaya, and Lucerne. The activity of faricimab may be derived primarily from its ranibizumab arm. So this is, there was no proven clinical benefit with ANG2 inhibition. Could be that the higher molar dose of ranibizumab FAB arm may be responsible for the faricimab treatment effect. There is a disparity in vision gains among faricimab treated patients, as was evident when the treatment arms were separated in year 1. The FDA analysis of year 1 data revealed that in Lucerne patients receiving a Q12 faricimab lost vision over time. And in the Tenaya patients receiving Q8 and Q12 faricimab also lost vision over time, suggesting that they may be having an undertreated, they may have been undertreated. A similar analysis of the year 2 results may provide insights into differences in treatment response between the faricimab 6 mg dose groups. So does faricimab offer durability advantages versus aflibercept? There is no direct comparison of durability in neovascular AMD because of the phase 3 study design. Select baseline characteristics in Tenaya and Lucerne suggest patients were good candidates for extension in neovascular AMD. So the contribution of ANG2 inhibition to the treatment effect and clinical response for neovascular and DME has yet to be established. So with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. Increasing the molar dose of anti-VEGF agent may have the potential to offer patients more through extended VEGF suppression. Have we maximized outcomes for our patients, or can we go further with disease control? Aflibercept 2 mg has set the bar high for treatment of exudative retinal disease, with novel agents yet to surpass its standard of care vision gains, durability and safety profile across indications. Aflibercept targets the key ligands of the VEGF pathway, the master regulator of pathological angiogenesis. Targeting other pathways has not resulted in improved patient outcomes beyond aflibercept. Data from Pulsar and Photon suggest that aflibercept 8 mg, which is due to become available in India shortly, has potential for greater and longer lasting control of the underlying disease compared with aflibercept 2 mg through sustained disease control. Thank you. At this point, I would just like to share, some case which I have. I think it's here only, sorry. So this was a case, first came to us in 2016, known case of diabetes type 2 since 94. Initial diagnosis which we made was high-risk PDR in the right eye with CSME and pre-retinal hemorrhage, and OS moderate NPDR, and underwent a lot of laser, and you can see the number of injections there, about 6 Lucentis, 1 Eylea, 5 Ozurdex in the right eye, and 4 Lucentis and 1 Ozurdex in the left eye. This was how the systemic parameters looked, so they were fairly well controlled. And this is the initial clinical picture with a vision of 612 parts in the right eye and 66 parts in the left. And underwent these injections and laser. You can see a fair amount of macular edema in the right eye. And left eye underwent 2 sittings of sparse PRP initially. And then had these injections over the successive years, 2016, 2017, even Ozurdex was given in the right eye. But the edema would come back with, very regularly. Patient underwent cataract surgery. I'll be just finishing in 1 minute. And finally, the patient was switched over to Eylea in the right eye in 2019. And this is what the patient looked like about 4 years down the line, and with a fluctuating course of macular edema. And between 2020 and 24, in the last 4 years, again patient received predominantly Eylea injections and has good resolution of DME with injection Eylea as compared to Ozurdex. And this is the final follow-up that we have very recently, where the patient is doing fairly well with very less requirement for anti-VEGF treatment, mostly stabilized. And the left eye has shown a few spikes of edema, but again with Eylea it's controlled well. Thank you.
I think, sir, a very interesting talk. As far as these, if you go purely by molecular characteristics, sir, I find it rather confusing at times, because our interest is potency and duration, majorly. So many times I find the various molecular characteristics not commensurate with what I expect. But your summarizing these things will probably give us a better idea in general.
So like, as there is a gap between Lucentis more than 1 month, is the similar gap, can we increase with Eylea also more than 1 month?
More than 1 month, I couldn't get the question.
What I mean is, in between 2 Eylea injections, how much gap we keep for DME or NAMD? Is it different?
So normally we know that Eylea, it lasts for about 6 weeks, as opposed to the monthly, regimen which we used to follow for ranibizumab, because it is definitely a stronger agent than ranibizumab. So, we definitely watch for 6 weeks, and only after that, we need to, consider repeating an Eylea injection.
So it was the same for DME and AMD both?
No. So, in DME, initially, I think what has been advised is that we use up to 6 loading doses, which again in the Indian context becomes very difficult. It is very almost, impossible to convince the patient to go for 6 injections in the beginning. So we end up, mostly initially on a loading dose, but not 6 for sure, maybe 2 to 3 injections. And then after that we watch, for the edema to come back, and then we can retreat. Yes.
Very nice presentation, Dr. Saurabh. I think it's beyond doubt now that with both the drugs being in the market for long, I think both are equally safer. And so I think that part is out of question now. I think what needs to be seen now is that obviously, this data does have a little bit of this thing, because we could say that it was a little biased because of 2 weekly and 6 weekly, but then that was a protocol which had to be followed in some way. I think it would be interesting to see, as you had shown the last slide, with 8 mg coming in, then we'll really know where we stand and which would be the most beneficial for the patients. But as of now, I think both seem to be quite wonderful, doing very well.
Until now, I think in the Western world, no safety data has come out, of concern for Eylea, HD. So I think, that is a promising treatment approach that we might have soon.
Yeah, maybe they can plan a more balanced trial.
Right.
Yeah.
Sir, regarding the increasing dose, sometimes we use Zaltrap, that is kind of a Avastin kind of thing. So sometimes we are not able to titrate the exact dose. So some patient might get an extra dose, and I see those patients who have got an extra dose, they developed inflammation.
They did?
Inflammation.
They did develop inflammation, okay.
With Zaltrap? Very mild inflammation which goes away within a week or
with
5
Zaltrap?
days.
With Zaltrap?
No, not with Zaltrap, with higher dose.
Okay, but again, when you've not titrated the dose, it's really difficult to say. But once we have an 8 mg volume of that drug, then I think we'll be in a better position to comment whether we see anything of the sort that we see with the higher molar dose with the other 2 injections that we have been seeing. Not very common, but I've seen in my practice with the heavier molecules, the higher molality molecules.
Oh.
Thank you.
Thank you, sir.
Thank you.